I'm embarrassed to be talking about this subject with Dr. Miller here because he knows so much more than most of us on it. That having been said, what I will talk with you about in a few minutes is diagnosing non-malignant asbestos disease in 2007. And I will skip a few slides kind of quickly because I'm told that not many people want to see pictures of tissue. First, let me explain to you what our approach is at Karmanos, why I think it is best, frankly. For years and years, for decades, since the danger of the asbestos fiber was first recognized in some quarters as a workplace hazard, there has been health screening, if you will, for diseases caused by asbestos. In other words, this entire X-ray system of B reading was set up to do screening of workers to codify any abnormalities on chest X-rays to identify if they had asbestos-related disease or not, or silica-related diseases, or other dust-caused diseases. And then mindful that anywhere, depending on whose literature you read, 8 to 20% of the chest X-rays are negative, even when a CAT scan or a pathological examination of the tissue would show asbestos scarring. That has nonetheless been sort of the accepted standard, not only medically, but especially legally, and especially through the government. Well, to do that in 2007 with the availability of high-resolution CAT scans, in my opinion, is like depending on 1950s medicine. It just doesn't make sense. So what we do at Karmanos, which is frankly fairly sophisticated and fairly expensive, and we couldn't do this on large groups of people for screening purposes, is look at the patient's symptomatology, look at the patient's history, look at the epidemiology in which the patient falls, and then move forward from that point. This approach, in honesty, grew out of the basic practice of good, solid scientific medicine, whether you're looking at asbestos fibers or not. I became convinced it was actually the valid way of doing things in my own personal experience when I examined a group of miners from the Iron Range in northern Michigan, from Negaunee. And I saw, at the request of the Steelworkers Union, I think about 200. This was in 88, I believe. And they clearly had asbestosis. There were at least 2/3 of high seniority workers in the mine who had asbestosis. And of course, the Mining Safety and Health Administration told me there is no asbestos in those mines. They can't have asbestosis. So I spent literally months wondering if it was in the blasting caps and looking here and looking there. We actually buried a couple of patients who had asbestos fibers isolated from the vicinity of their lung tumor. So I just became convinced that there was asbestos and these patients had asbestosis, even though the Mining Safety and Health Administration told me that we were wrong. Well, for some of you, as you know, in the last couple of years, MSHA realized that they'd been using the wrong kind of microscope. And they said, gosh, we're sorry. I guess the patients who died from asbestosis really did die from asbestos-related disease because we found those fibers in our new microscopes. So it's an approach to patients that a good, competent physician would use if he didn't know anything about asbestos, basically. This is the asbestos body that's formed once these fibers are breathed in. Asbestos exposure causes, as you know, asbestosis, which is nothing but scarring of the lungs caused by the asbestos fiber, pleural plaques, a thickening on the covering of the lung, obstructive airways disease. I put this in here because this has been controversial. The American, although I don't really understand why, because Margaret Becklake in Quebec reported this decades ago, and we, on the American Thoracic Society committee that was responsible for developing the ATS position on asbestos disease diagnosis, felt strongly that the fiber does cause obstructive disease. Now, it is uncommon for the fiber to cause clinically significant obstructive disease in and of itself, but nonetheless, it is extremely important to remember that it does cause obstructive disease, and cancer of the lung and colon, mesothelioma, and other cancers. This is just so you can see, for those who don't know what a pleural plaque looks like, that's a pleural plaque, that thickened sort of ugly stuff. And this is what a real lung looks like with asbestosis, just so you can get an idea what it looks like. So the idea of an evaluation for non-malignant disease is to try and find out what is going on in the body that creates this process without actually going in and having to take out the lung. Among the things I mentioned and the things that we look at are people people's exposure histories. These are people who we know historically have exposure to asbestos and who, if present to a physician's clinic with shortness of breath, this minimal occupational survey should be done to find out if there's a likely history of exposure to asbestos fiber. Of course, this is much more expanded now, especially in light of the Libya experience and the shipment of asbestos fibers throughout the country. Where have people died from asbestos-related deaths? We have a lousy system of asbestos death registry, or a non-system, in most places in the country. So these dots were sort of picked up by accident. In the case of Michigan, which I know, we see a big concentration around Detroit, big concentration around the Dow Chemical Company, and wherever else there are concentrations, they tend to be industrial facilities. Another thing that I've come to recommending in the last 2 years that physicians look at is find out where the person lived or where they grew up in relationship to where vermiculite was shipped from Libya. And those are the major sites. Now, there's no science on this yet, mind you, but if there's an asbestos repository in your neighborhood and you have trouble breathing and have scarring on your lungs, it's worthwhile to find out if you live near the place where a lot of asbestos came from. The latency periods that Linda discussed, and these are other things that go into the diagnosis of asbestos-related disease. We usually think pleural changes take 10 to 20 years. Actual scarring from asbestos takes 15 to 30 years. The lung cancer is 20 to 30, and the mesothelioma is 30 to 40. But that's not true now. It's certainly not true across the board, but we know these are rough rules of thumb. The pleural plaques, you remember what they look like, those sort of ugly things? This is what they look like when they're quite advanced on a plain chest film. And this is a chest x-ray showing some pleural plaques and a little bit of asbestos scarring. But this is a CAT scan, and you get a much better picture of the scarring. You already know this, but I just want you to take a look at these. So what's the criteria for diagnosis? Well, in 1986, the American Thoracic Society put forth some criteria. 2004, they were updated. And I'm not going to go through this slide, but I just want you to see there are some changes that I sort of summarized in here. What kinds of things do I think physicians should do when patients present with asbestos, the possibility of an asbestos-related disease? Or a patient who's short of breath at going up one flight of stairs, or a patient who notices an increased inability to walk quickly. Complete pulmonary function tests. I think our previous standard of doing spirometry as required by the OSHA standard is kind of like asking a sailor to go, 2 minutes, okay, to go across the ocean in a rowboat. Doesn't make sense. 2007, for God's sake. We can precision bomb somebody's back door in a third world country. We can certainly do better than the same sort of pulmonary function testing that was developed in 1918. Airways conductance, airways resistance is important, diffusing capacities. 6-minute hall walk. This is where you go to the doc and everything looks pretty good on the pulmonary function test. Doc can't find a lot. It's a very simple thing. You put in what's called a pulse oximeter on the finger. It measures the saturation of oxygen, and you walk up and down the hall for 6 minutes. This reveals an enormous amount of disease, which is undetected otherwise. Lung biopsy, maybe. If the physician is competent and experienced and can't rule out other causes, you may need a lung biopsy. Serial testing, I want to come to in a second. Radiology. I think the state of the art is a 64-slice high-resolution CAT scan. Not everybody's got them. In next year, it'll be 128 slices more regularly available. But right now, if you're trying to make a diagnosis and you're trying to figure it out, I think it's 64 slices that indicated. I want to tell you real briefly, on serial testing, you can't always tell when people have multiple exposures. For example, a tunnel worker, and I don't want to talk about the tunnel workers, but as an example, a tunnel worker, because that's an example that we can look at right today, where there are multiple exposures. An asbestos-related lung disease may not be evident on the CAT scan, the PFTs, and in the exam today, because there may be concurrent other exposures which can look like asbestos, or which may fool the physician. For example, certain other dusts or certain mold inhalations can cause what's called hypersensitivity pneumonitis, which can look a lot like asbestos. So you repeat the studies every year or two for a few years, and if they don't go away or they get worse, then you think more in terms of asbestos. If they get better, you think in terms of something else. One last thing I want to talk about in detection is serology. You know, at Karmanos, we're pretty proud of ourselves that we reported the osteopontin levels that are elevated in mesothelioma. We're pleased to be looking at using the mesomark test clinically for non-FDA approved uses in the United States, but it's approved everywhere else. And I guess the lady from Mesomark shouldn't have heard that. But as a tumor marker, there was a very interesting report last year that osteopontin levels are also associated with pulmonary fibrosis. And there is a study in animals, which we hope to expand on at Karmanos in the coming few months, that showed that if you use two different drugs, one called interferon, the other pirfenidine, in combination, you can actually lower the osteopontin levels. Now, we don't know what that means. And I'm not saying that rhetorically. I don't know what that means. But what it could mean is that we can slow down the progression of fibrosis, or we might be able to prevent a tumor or two because of lowering the osteopontin. We don't know if the osteopontin lowering is a result of lowering the marker or lowering the place where the osteopontin is coming from. So it's sort of an exciting development that we hope to more thoroughly investigate in the next 12 months. That's my 10 minutes. Thanks. Sorry I went so fast.